Yeah, so I'm a neuroradiologist, so I deal with medical imaging of the brain, neck, and spine. So I wanted to talk about imaging and molecular updates of brain tumors, which is highly relevant to a translational genetics audience. And so these are my grants, and just wanted to acknowledge some of my colleagues. So today we will discuss the World Health Organization 2021 updates and classification of brain tumors, which has several important molecular, in particular, updates. Identify opportunities for utilization of advanced imaging, so not just our basic medical imaging, but cutting-edge techniques that help describe tumor biology, and then correlate the molecular and radiologic characteristics of brain tumors across the lifespan, both adult and pediatrics. So in the World Health Organization 2021, it's a very new, hot off the press. I think the print edition is actually still in the works, but you can check it online and subscribe. But there's this concept of the layered report, which has really evolved from the prior edition. And so traditionally we look at histology. So we look at slide and morphologic characteristics. We look at tumor grade from 1 to 4. And then we also look now more at molecular testing. So it's really all of these layers together providing an integrated diagnosis. Because we continue to identify new genetic pathways and understand their effect on patient outcomes, the taxonomy is evolving, and the whole idea is to have a precision medicine approach where we have better diagnosis, prognosis, and treatment of these patients with different types of molecular variants. So one question is, why do we do medical imaging? Well, there are several important reasons. We want to look at the precise location and extent of the tumor. Where does it invade for the surgeon to plan, as well as are there metastases throughout the rest of the central nervous system and the body? We want to be able to look non-invasively at the tumor, its size, its behavior over time, without actually having to go in and take out tissue or invasively open the body. And we also want to be able to use advanced sequences that can provide biologic information about the tumors rather than just anatomic. So this is the summary paper, which I highly recommend for anyone who's interested in terms of the updates for 2021 WHO classification. This summarizes actually a series of 7 intermediary meetings, which were performed by a series of primarily neuropathologists around the world and a couple neuro-oncologists to really discuss what the key updates should be in classification since the prior 2016 classification. So first I want to talk a little bit about advanced imaging techniques because not everyone will have been exposed to these. So when we're gathering information about brain tumors, it's really like good reporting, we have the 5 Ws. And so we're looking at the patient age and the time course of onset. And then with imaging, we're looking at the location of the tumor and what it's comprised of, its contents. And then we put all of this together to determine the tumor etiology. So some of the advanced techniques that may not be as familiar to this audience, and we're talking now about magnetic resonance imaging, which uses magnetic fields to image brain tumors. You can look at tumor anatomy, but you can also look at things like density and also white matter fibers. So how do the critical fibers pass through the tumor, which is important for the surgeon when they're looking at function and preserving function when resecting a tumor. You can look at tumor flow as well. So there are many different ways to measure flow within tumors. There are techniques that don't require the use of intravenous contrast, that you can actually just look at capillary density. You can give contrast within a vein, and then looking at the first pass of contrast through the tumor, you can determine relative cerebral blood flow of tumor versus normal brain. You can also image the tumor over time and actually look at the kinetics as contrast exchanges between the vascular space and the extracellular space. So this tells you about permeability characteristics. And so each of these sequences can be used to help with surgical planning to see, what are the highest areas of tumor vascularity so that you make sure you're biopsying the highest grade area and representing what you need to do in terms of resection and treatment. We can do this with the non-contrast techniques as well as the contrast techniques, really targeting the highest areas of tumor for the surgeon, and also looking at permeability, which tells you more about tumor biology. We also do functional imaging. So this is really looking at blood flow before and after certain tasks, particularly motor and language tasks. And what we're doing here is trying to figure out if critical areas of brain are close to the area of tumor, because if they overlap the area of tumor, you cannot take the entire tumor out without removing critical, for example, motor or language functions, which you don't want to do. So in this case, the tumor is far away from the critical function, so it can be completely resected. But in cases where the tumor is more infiltrative and involves these critical areas, you may want to do a subtotal resection and have the surgeon do an awake craniotomy so they can actually test in real time whether a certain area of brain is particularly critical to patient function. We also have spectroscopy, which is really looking at tumor metabolism. So in these cases, when you have a complex tumor that's been partially treated, you can distinguish areas of treatment change and necrosis from residual tumor as well as recurrent tumor. We have positron emission tomography, which is actually a nuclear medicine technique requiring injection of a radiotracer. But this can tell you about tumor metabolism, glucose metabolism in the case of traditional PET, but we have a number of emerging tracers that look at amino acid metabolism, hypoxia, and other biologically relevant parameters. And then we have things that are coming down the pike in terms of new techniques. So this is an MRI technique that has emerged in terms of non-invasive and non-radiation alternative to PET, and can look at aspects such as tumor metabolism, pH, and brain injury. So being able to compare, for example, the concentration of proteins within a low-grade versus a high-grade tumor. We can also do looking at other nuclei besides hydrogen. So hydrogen water molecules are our most frequent nuclei in the body. And so traditional clinical MRI measures proton nuclei, but there are vendors now offering, all the major vendors are offering multinuclear imaging, looking at, for example, sodium and phosphorus, the next most common nuclei in the body. And obviously, because of the lower concentrations, the resolution is lower, but you can start to look at things like ion homeostasis and energetics as well. So that's kind of a look at the future. So the rest of this talk will be looking at the imaging characteristics and the molecular features of various brain tumors, first in the adult and then the pediatric population. So the updates for WHO 2021 in adult type diffuse gliomas. Now these are essentially infiltrative, poorly defined gliomas that typically occur in adults. They can occur in younger patients, but classically the behavior and the presentation is in adults. So it's actually much simplified from 2016. If you have the isocitrate dehydrogenase mutation, then that's a good prognosis. If you have the 1p19q co-deletion, it is by definition an oligodendroglioma, which is the best prognosis. If you do not have 1p19q and or you have one of these defining mutations, it is known as an astrocytoma, which is kind of an intermediate prognosis. And then the IDH wild type tumors are now exclusively glioblastomas. These are the most aggressive biologic tumors. There are no longer any grade 4 tumors with IDH mutation known as glioblastomas. These are now all known as astrocytomas. Depending on the molecular mutation, they may have poor biologic prognosis, but essentially we now have a very granular division between these three groups of tumors. Some glioblastomas are very classic histologically with the microvascular proliferation and necrosis, but some of them actually are molecularly defined because even without the classic histologic features, outcome studies have shown that these types of mutations are very poor prognosis, very short life expectancy. And so all of these, whether molecular and or histologic, are defined as glioblastoma. 2-hydroxyglutarate, or 2-HG, is an oncometabolite that is overproduced in IDH mutation tumors, so either IDH1 or IDH2, and it has characteristic spectroscopic signature with peaks at 1.9, 2.3, and 4 parts per million. The 2.3 is the highest one, but there are some areas of potential overlap with glutamine in a traditional normal spectroscopic signature, as well as areas of necrosis. Even in IDH wild-type tumors like glioblastoma, necrotic areas can have a broad lipid peak, and that can overlap the normal 2-HG peak. So having your spectroscopist actually do some spectral resolution and make sure that These peaks truly represent 2HG, and summing the three areas is helpful for specificity and also avoiding interrogating areas of necrosis when you're doing the scan. So here's an example of an oligodendroglioma. This is a very classic one, involving the cortex, frontal lobe with calcification, and had that classic molecular codeletion. Here we have a characteristic astrocytoma, lower grade in the peri-insular region, a little bit more infiltrative in appearance, and is IDH mutated, but does not have that 1p19q codeletion. This is another IDH mutated tumor, higher grade now. This is also astrocytoma, no 1p19q. Notice this interesting feature that T2 is a fluid-sensitive sequence, and FLAIR is also a fluid-sensitive sequence, but with suppression of normal serous fluid or cerebrospinal fluid. And so you see that there's a few areas that drop out between the two sequences. So there's some fluid here, but it's more serous or simple fluid. And so this is known as the T2 FLAIR mismatch sign. In fact, this is a highly specific, not necessarily sensitive, but highly specific, almost 100% specificity and positive predictive value for IDH mutated astrocytomas. Pathologically, it seems to correspond to, again, the serous fluid enlarged intracellular spaces as well as intercellular spaces. So the presence of more serous fluid, whether it's within the cells or between cells. And so that corresponds to these kind of simple cystic areas. So you don't always see this, but if you do see that T2 FLAIR mismatch or dropout, that's very suggestive of IDH mutated astrocytomas. And then we have a grade 4 astrocytoma where it doesn't look all that bad on imaging, but it has this characteristic ATRX loss, which means biologically aggressive grade 4, poor prognosis. And so this is a situation where the molecular definition now gives you this new classification of the grade 4 astrocytoma. No 1p19q testing required because we have the definitive molecular feature of an astrocytoma. Now we move to glioblastoma. So this is IDH wild type, but it has this molecular defining mutation. So even though the imaging features are not necessarily as ugly as you see in a lot of glioblastomas, it's not all that enhancing, it's not all that necrotic, but this mutation means that the patient won't do very well in correlative studies. And so they have a molecular definition of glioblastoma, grade 4. And this is now your classic glioblastoma on imaging and histology, very ugly enhancement, internal necrosis, some areas of hypercellularity, and IDH wild type. So that is basically correlating across all of the layers of the diagnosis. So next I move to pediatric type gliomas. So these, we have really advanced our molecular understanding since the prior classification. And so these have actually gotten a little bit more complex, but as I said, it's evolving. The diffuse gliomas, again, these are the infiltrative, poorly defined ones. So we have 4 low grade, 4 high grade, and a number of different molecular pathways that have been linked. With the high grade ones, we're looking at a lot of this histone protein responsible for chromatin packaging and stabilization. So this is a nice little review graphic which shows you the high grade and low grade pediatric type tumors, kind of their relative locations in the midline or more lateral, and the related molecular pathways. We also have circumscribed tumors. So these are the ones that are more well defined in imaging. And although some of them do have analogous alterations in molecular pathways, they have very different prognoses because of their margins. And so the growth pattern, the imaging, the histology is also highly relevant because obviously some of these are common pathways for tumor neogenesis, but not all of them will behave as aggressively in terms of their growth and metastasis pattern. We also have glioneuronal and neuronal tumors, which have stayed relatively similar in classification since the prior classification. So in kids, we have these LEETs or long-term epilepsy-related tumors where they're well circumscribed. They can be these little separate nodules, or they can be a little bit more bubbly and microcystic, but very similar density to regular brain. And also your run-of-the-mill, these are very common pilocytic astrocytomas. So these are all low-grade tumors, which are very relatively well-defined margins, not aggressive, not infiltrative. And they can actually be very stable over time. So with involvement of the cortex, you may present with epilepsy, but if you actually take these tumors out, the patients do very well. And even if you just watch them over many years, they grow either minimally or not at all. And so there's actually a whole set of different histologies, which someone's essentially assigned, these alphabetical letters from A through I, which may be overkill. But the idea is that many different low-grade tumors can behave this way. And other than seizures, they behave very indolently from a biologic standpoint and can be watched for many years. The diffuse leptomeningeal glioneuronal tumor, a relatively newly described entity, these present throughout the subarachnoid space. They tend to not have a primary intraaxial lesion, but if you do see one, it's typically in the spinal cord. And the update for 2021 is that these are linked to the MAPK pathway, BRAF fusion protein constructs, but they're actually two methylation classes. So the first one has oligodendroglioma-like features. So, very hypoenhancing and kind of almost cystic looking younger patients. The second methylation class has an instability gain of chromosome 1q. These patients are older and more aggressive tumors. You can see more expansion, more enhancement of the subarachnoid space, and invasion of the sinuses, and also diffuse coating and compression of the cord. So even within this tumor type, there are more aggressive subtypes based on molecular testing. We have overgrowth syndromes. These, as you know, are related to the mTOR pathway, but you can have mosaic involvement rather than germline. And so you can get anything from very focal involvement of a cortical dysplasia, where you just have like a small region of overgrowth and disorganization. You can have part of the brain, so whether it be a lobe, a quadrant, half the brain, or the whole brain, depending on what stage, what zygotic stage you acquired the mutation at. And then you can have tuberous sclerosis, where essentially you have multiple dysplasias throughout the brain. And all of these are essentially areas of overgrowth. You can even have low-grade hamartomas that have a risk of degenerating into grade 1 tumors or subependymal giant cell astrocytomas. But these are all related to mTOR pathway and overgrowth and dedifferentiation. Pediatric high-grade gliomas, as I mentioned, are linked to this chromatin protein. It's thought that the oligodendrocyte precursors actually acquire the mutation, and that leads to tumor predisposition later in life. So we've known about the diffuse midline glioma for some time, the histone 3 K27M mutation, and these have a lot of near the midline tumors throughout the brain, the brainstem, the spinal cord, and have a poor post-treatment prognosis. There's a new classification, the histone 3 G34 altered patients, where they tend to have more hemispheric rather than midline tumors, but also very aggressive looking. The embryonal tumors, we have the embryonal tumor with multilayered rosettes, and we now have some chromosome 19 that has been linked to these, the epithelial mesenchymal transition, and also the Dicer-1 syndrome, in which you can have multiple tumors of various organs. Medulloblastoma is your classic embryonal tumor, and there have been for some time 4 different groups based on molecular subtype: the wingless, the sonic hedgehog, and group 3 and 4, which are neither wingless or sonic hedgehog. So each of these has very distinct embryonic precursors and therefore locations and appearances in the brain. And there are additional molecular features which can give you poorer or better prognosis. At the moment, we have 12 subtypes of these 4 groups, but I'm sure that will change as we learn more. The other important thing about medulloblastomas is that there are many familial cancer germline syndromes which can be linked. So it's important to do family history and potentially genetic testing to see whether the patient has one of these other predisposition syndromes and may develop tumors of other organ systems. So just some imaging examples. We have the sonic hedgehog, which are desmoplastic nodular, very dense nodular hypercellular type tumors. And if they have the TP53 mutation, even more aggressive and can have some necrosis. The wingless tumors tend to be around the cerebropolytone angle, so you can see how they're involving both brainstem and cerebellum. And then group 3 and 4 are more midline and less enhancing. The other important thing is the metastasis pattern. So there's a chemokine, this chemokine receptor pathway, which has been actually determined to actually characterize the leptomeningeal spread, because medulloblastomas are actually metastatic in the blood at presentation, but whether they actually develop macro metastases in the leptomeninges, in group 3 and 4, we see these metastases actually homing to the leptomeninges. So with the wingless subtype, you do not have that mutation, so they tend to not metastasize. Sonic hedgehog may have just some regional areas of spread because of that desmoplastic nodular pattern. But the group 3 will have characteristic laminar leptomeningeal metastases, and then group 4, more of these nodular kind of non-enhancing metastases. But again, modulated by this blood-brain barrier transport with the chemokine receptor alterations. The atypical teratoid rhabdoid tumors are linked to this, very poor alteration of this pathway. So you get a bunch of rhabdoid tumors, schwannomatosis in various organ systems, and a number of molecular enhancers have been described as well. So we have both supratentorial and infratentorial, but very ugly necrotic kind of hemorrhagic tumors, sinonasal tumors, renal tumors, core tumors. Ependymomas have now been classified. These are still very molecularly heterogeneous, but classified by the compartment in which they arise. The supratentorial brain has a couple different classes of molecular configuration. The posterior fossa, which is your classic, now has group A and B. The younger, more poorly performing unstable methylation, and then the older midline tumors. And then our spinal tumors, which there's one class that's now very infiltrative leptomeningeal spread. And so by definition, the ependymomas are grade 2 to 3. The subependymomas have a similar compartmental classification, but these are grade 1 and less aggressive looking from imaging. So these are examples of ZAFTA stem cell transformed supratentorial ependymomas. And then we have the two classes of the infratentorial ependymomas, the more aggressive pediatric ones, and then the older, less aggressive adult ones. The solitary fibrous tumor has been reclassified. It used to be known as hemangiopericytoma in the brain, but now all three grades have been essentially homogenized with soft tissue tumors and are known as grade 1 to 3. We also have a new fusion protein, which is seen in all of these tumors and determines the aggressiveness of whether it involves bone and soft tissues or not. The nerve sheath tumors also have some new classifications. So there's a melanotic form with this intrinsic T1 shortening, the melanin protein, and these are seen in a couple different mutations and also the Carney complex. A number of genetic tumor syndromes and hybrid nerve sheath tumors have also been described where they're not quite the classic neurofibromas or schwannomas or perineuriomas, but something in between in histology. And so those are just very interesting as well. We have NF1, NF2, and NF3, so 3 types of neurofibromatosis, which are all linked to different genetic loci, and they have slightly different types of tumors and skin findings and eye findings. So with NF1, we have optic pathway gliomas, plexiform neurofibromas of the head, neck, and spine. In NF2, we have multiple meningiomas, nerve sheath tumors, cranial nerve and spinal nerve tumors, and meningiomas, ependymomas. And in NF3, we have schwannomas, sometimes plexiform schwannomas, and rhabdoid tumors. Neuroendocrine tumors in kids, we see glomus tumors, particularly with the SDH mutation for mitochondrial oxygen sensing in several different classic locations. And you can also see neuroendocrine tumors in NF1, in von Hippel-Lindau, and in multiple endocrine neoplasia. So just a lot of different genetically driven tumor predisposition syndromes. The cord plexus tumors have been linked to TP53, which you see in a lot of different cell cycle things, but stress response. So this really determines the grade of the cord plexus tumor, whether it's well defined, within the ventricle, whether it starts to be invasive and have leptomeningeal spread, or whether it's frankly invasive into the brain parenchyma. And then for pituitary lesions, the adenomas have been proposed to be reclassified as pit nets because they are they really involve not just the morphologic characterization, but also the functional, looking at the hormonal expression. And these will have that characteristic kind of hypoenhancement relative to the normal pituitary parenchyma, which is a circumventricular organ without a blood-brain barrier. Langerhans cell histiocytosis has been linked to this clonal proliferation of BRAF, the MAPK pathway, and these are characteristically within the the infundibular part of the pituitary, as well as bone lesions. And then the craniopharyngioma has 2 subtypes, which have now been completely split out. The adamantinomatous one is the one that's classically seen in children and is linked to this beta-catenin pathway, but has that kind of crankcase oil appearance with complex solid cystic, invasive, very sticky appearance. And then lastly, the pineal region tumors, we have the pineocytoma, which is well-defined, with physiologic internal calcification. That's grade 1. The grade 4 pineoblastoma, which is an exploded calcification, very aggressive, and now has actually 4 different molecular subtypes, which correlate with outcomes and patient presentation. And then we have the intermediate, grade 2 to 3 tumors, which are essentially in the middle, both histologically and morphologically. The differential for the pineal lesions is going to be your germ cell tumor. So these can have pineal, pituitary, and everything in between. But what you're really looking for here is CSF dissemination. For basically, these lesions can arise throughout the CSF space and really just seed the leptomeningeal space. And so that's what you're looking for. Obviously, the tumor markers are very helpful for determining what subtype of germ cell tumor it is, and these can be responsive to chemotherapy and targeted therapy. There are many different genetic pathways involved, but global demethylation and chromosomal instability is a common feature. So in conclusion, integrated diagnosis of brain tumors involves a combination of histologic imaging and molecular features. The use of advanced MRI provides us additional information about tumor biology, and imaging genomics, this idea of precision medicine, will enable us to do better, faster, and more accurate diagnosis, prognosis, and treatment for patients. Thank you very much for your attention.